Question 1. A critical care nurse is managing a patient with septic shock who remains hypotensive despite adequate fluid resuscitation and is now receiving norepinephrine. The nurse notes the patient's heart rate is 125 bpm, CVP is 14 mm of mercury, and SCVO2 is 62%. Which intervention would be most appropriate at this time? A. Increase the norepinephrine infusion rate. B. Administer an additional fluid bolus. C. Initiate a dobutamine infusion. D. Prepare for initiation of continuous renal replacement therapy, CRRT. Answer: C. Initiate a dobutamine infusion. This question tests the management of septic shock and understanding hemodynamic parameters. The keywords remains hypotensive despite adequate fluid resuscitation and SCVO2 is 62% are crucial, indicating that fluid volume is likely optimized, CVP 14 mm of mercury, but tissue oxygen delivery is inadequate, SCVO2 less than 70%, despite vasopressor support for blood pressure. A low SCVO2 in a patient with adequate preload and blood pressure suggests impaired oxygen utilization or low cardiac output. Initiating dobutamine, an inotrope, would improve cardiac contractility and cardiac output, thereby increasing oxygen delivery and improving SCVO2. Remember that in septic shock, after fluid and vasopressor support, if perfusion targets, like SCVO2, are not met, improving cardiac output with an inotrope is the next step. Question 2. A patient admitted with severe acute pancreatitis develops sudden shortness of breath, a respiratory rate of 30 breaths/min, and crackles in the lung bases. ABG results show pH 7:30, PaCO2 50 mm of mercury, HCO3 24 milliequivalent/L, and PaO2 60 mm of mercury. The nurse anticipates which primary intervention? A. Administer sodium bicarbonate. B. Prepare for endotracheal intubation and mechanical ventilation. C. Increase oxygen delivery via non-rebreather mask. D. Administer a bronchodilator. Answer: B. Prepare for endotracheal intubation and mechanical ventilation. This question assesses the interpretation of ABG results in a patient with severe respiratory distress, a common complication of pancreatitis. The ABGs indicate acute respiratory acidosis, low pH, high PaCO2, normal HCO3, with hypoxemia, low PaO2, combined with significant clinical signs of respiratory failure like tachypnea and crackles. While increasing oxygen delivery is helpful, the primary issue is hypoventilation leading to CO2 retention and severe hypoxemia. The patient's clinical presentation and ABGs collectively suggest impending or actual respiratory failure requiring definitive airway management to support ventilation and oxygenation. Question 3. A 68-year-old male presents to the ED with complaints of epigastric pain radiating to his jaw, accompanied by nausea and diaphoresis, which started an hour ago. His ECG shows ST elevation in leads 2, 3, and AVF. The nurse recognizes this as an acute inferior myocardial infarction and should prioritize which intervention? A. Administer a sublingual nitroglycerin tablet. B. Prepare for immediate cardiac catheterization. C. Initiate an intravenous infusion of metoprolol. D. Obtain an order for a proton pump inhibitor. Answer: B. Prepare for immediate cardiac catheterization. This question focuses on the immediate management of acute ST elevation myocardial infarction, STEMI. The keywords epigastric pain radiating to his jaw, nausea, diaphoresis, and critically, ST elevation in leads 2, 3, and AVF definitively diagnose an acute inferior STEMI. The absolute priority for STEMI patients is immediate reperfusion to restore blood flow to the ischemic myocardium and minimize infarct size. Cardiac catheterization for percutaneous coronary intervention, PCI, is the gold standard for rapid reperfusion and must be prioritized over other interventions, which might be secondary or contraindicated in certain STEMI types. Question 4. A patient with end-stage renal disease on hemodialysis develops severe hypokalemia, potassium 2, 5 milliequivalent/L. Which electrocardiogram, ECG, changes would the nurse anticipate observing? A. Peak T waves and widened QRS. B. Tall, tented T waves and prolonged PR interval. C. Prominent U waves and flattened T waves. D. Shortened QT interval and elevated ST segment. Answer, C. Prominent U waves and flattened T waves. This question tests the nurse's knowledge of the ECG manifestations of electrolyte imbalances, specifically severe hypokalemia. The key is to distinguish between the effects of low versus high potassium. In hypokalemia, the myocardial repolarization is prolonged, leading to characteristic ECG changes such as prominent U waves, a positive deflection following the T wave, flattened T waves, and sometimes ST segment depression. Peak T waves and widened QRS complexes are signs of hyperkalemia. Remembering the unique U in hypokalemia can help differentiate it from hyperkalemia. Question 5. The critical care nurse is caring for a patient on mechanical ventilation for acute respiratory distress syndrome, ARDS. The patient's peak inspiratory pressures, PIP, have increased from 35 cmH2O to 48 cmH2O, and the plateau pressure, PLAT, is 30 cmH2O. The patient's POW2 is 55 mm of mercury on FiO2 8. Which intervention should the nurse anticipate? A. Administer a bronchodilator. B. Reposition the endotracheal tube. C. Increase the positive end expiratory pressure, PEEP. D. Suction the endotracheal tube. Answer, C. Increase the positive end expiratory pressure, PEEP. This question focuses on managing ARDS and interpreting ventilator graphics. The key indicators are increased PIP with a relatively stable PLAT, suggesting increased airway resistance, and persistent hypoxemia, POW2 55 mm of mercury on FiO2 8, which is characteristic of ARDS. In ARDS, the primary issue is diffuse alveolar damage and fluid accumulation, leading to refractory hypoxemia and collapsed alveoli. Increasing PEEP helps to recruit collapsed alveoli, prevent derecruitment, and improve oxygenation, making it a crucial strategy in ARDS management when hypoxemia persists. Question 6. A patient with a severe traumatic brain injury, TBI, is intubated and sedated. The nurse observes an abrupt, severe increase in blood pressure, 190/100 mmHg, bradycardia, heart rate 45 bpm, and irregular breathing patterns. The nurse should immediately suspect which neurological phenomenon? A. Status epilepticus. B. Uncal herniation. C. Cushing's triad. D. Autonomic dysreflexia. Answer, C. Cushing's triad. This question tests the recognition of critical signs of increased intracranial pressure, ICP, in a TBI patient. The keyword abrupt, severe increase in blood pressure, bradycardia, and irregular breathing patterns are the hallmark components of Cushing's triad. This triad is a compensatory physiological response to severely elevated ICP, reflecting brainstem compression, and is an ominous sign of impending brain herniation. Immediate recognition and intervention to reduce ICP are vital to prevent further neurological deterioration. Question 7. A critical care nurse is preparing to initiate continuous renal replacement therapy, CRRT, for a patient with acute kidney injury and fluid overload. Which parameter should the nurse monitor most closely during the initial hours of CRRT? A. Serum potassium levels. B. Blood pressure. C. Blood urea nitrogen, BUN, levels. D. White blood cell count. Answer, B. Blood pressure. This question focuses on the immediate priorities during the initiation of CRRT. The keyword initial hours is critical, indicating the need to monitor for acute complications. While all listed parameters are important in the overall management of AKI, blood pressure is the most crucial to monitor closely during the initial hours of CRRT because rapid fluid removal can lead to hypotension, especially in hemodynamically unstable patients. Ensuring adequate blood pressure is essential to maintain tissue perfusion and prevent further organ injury. Question 8. A patient with severe traumatic injuries develops polyuria, hypernatremia, and a urine osmolality of 150 mosm/kg with a serum osmolality of 310 mosm/kg. The nurse anticipates the initiation of which medication? A. Desmopressin. B. Furosemide. C. Hydrocortisone. D. Regular insulin. Answer, A. Desmopressin. This question describes the classic clinical and laboratory findings of central diabetes insipidus, DI. The keywords polyuria, hypernatremia, urine osmolality of 150 mosm/kg, and serum osmolality of 310 mosm/kg clearly indicate that the kidneys are unable to concentrate urine despite high serum osmolality. Desmopressin is a synthetic analog of antidiuretic hormone, ADH, which is deficient in central DI, and its administration will help the kidneys reabsorb water, reducing urine output and correcting hypernatremia. Understanding the pathophysiology of DI and the mechanism of action of desmopressin is key here. Question 9. A critically ill patient requires frequent painful procedures. The family requests that the patient receive continuous sedation to minimize suffering, but the medical team is concerned about delaying neurological assessment. Which ethical principle is most directly in conflict in this situation? A. Justice. B. Autonomy. C. Beneficence. D. Non-maleficence. Answer, C. Beneficence. This question presents a common ethical dilemma in critical care, testing the understanding of core ethical principles. The keywords are family requests continuous sedation to minimize suffering, suggesting beneficence, acting in the patient's best interest by providing comfort, versus the medical team concerned about delaying neurological assessment, also suggesting beneficence, acting in the patient's best interest by obtaining necessary information for diagnosis and treatment. Beneficence is the principle of acting for the patient's good. In this scenario, there is a conflict between two beneficial actions, providing comfort versus facilitating diagnosis/treatment. Autonomy is the patient's right to choose, and justice is fair distribution of resources, neither of which is the primary conflict here. Question 10. A critical care nurse is monitoring a patient receiving a blood transfusion. 30 minutes into the transfusion, the patient develops a sudden onset of fever, chills, flank pain, and dark urine. The nurse should immediately perform which action? A. Slow the transfusion rate and monitor vital signs. B. Administer an antihistamine and continue the transfusion at a slower rate. C. Stop the transfusion immediately and keep the 4 line open with normal saline. D. Send a urine sample to the lab and obtain an order for acetaminophen. Answer: C. Stop the transfusion immediately and keep the 4-line open with normal saline. This question describes the classic signs and symptoms of an acute hemolytic transfusion reaction, a severe and potentially fatal complication. The keywords fever, chills, flank pain, and dark urine occurring shortly after starting a blood transfusion are highly indicative of this reaction. The absolute priority in such a situation is to immediately stop the transfusion to prevent further administration of incompatible blood. Maintaining 4 access with normal saline is crucial for administering supportive care and managing potential complications like shock. Question 11. A patient with suspected bowel perforation presents with acute abdominal pain, rebound tenderness, rigidity, and absent bowel sounds. Which nursing action is most critical in the initial management of this patient? A. Administer oral pain medication as ordered. B. Insert a nasogastric tube to decompress the stomach. C. Prepare for immediate administration of a barium enema. D. Encourage oral fluid intake to prevent dehydration. Answer: B. Insert a nasogastric tube to decompress the stomach. This question describes a patient with signs of an acute abdomen, highly suggestive of bowel perforation and peritonitis. The keywords acute abdominal pain, rebound tenderness, rigidity, and absent bowel sounds are red flags. In such a scenario, the most critical initial nursing action is to insert a nasogastric tube. This helps to decompress the stomach, reduce vomiting, prevent further spillage of gastric contents into the peritoneum, and prepare the patient for potential emergency surgery. Oral intake is contraindicated, and barium enemas are typically avoided in suspected perforations. Question 12. A patient admitted with severe sepsis develops acute respiratory distress syndrome, ARDS, disseminated intravascular coagulation, DIC, and acute kidney injury, AKI. The nurse understands that this progression most closely aligns with which clinical syndrome? A. Systemic inflammatory response syndrome, SIRS. B. Anaphylactic shock. C. Multiple organ dysfunction syndrome, MODS. D. Cardiogenic shock. Answer: C. Multiple organ dysfunction syndrome, MODS. This question describes a patient with severe sepsis experiencing the failure of multiple organ systems. The keywords ARDS, DIC, and AKI represent the simultaneous failure of respiratory, hematologic, and renal systems. This constellation of organ failures defines multiple organ dysfunction syndrome, MODS, which is a common and severe complication of conditions like sepsis. MODS is characterized by progressive physiological dysfunction of 2 or more organ systems independent of the initial insult. Question 13. A patient in the critical care unit suddenly develops a narrow complex tachycardia with a regular rhythm at 190 bpm. The patient is alert, normotensive, and denies chest pain or shortness of breath. The nurse should anticipate which initial intervention? A. Immediate synchronized cardioversion. B. Administration of intravenous amiodarone. C. Attempting vagal maneuvers. D. Preparing for transcutaneous pacing. Answer: C. Attempting vagal maneuvers. This question describes stable supraventricular tachycardia, SVT, a common arrhythmia. The keywords narrow complex tachycardia, regular rhythm at 190 bpm, and crucially, alert, normotensive, and denies chest pain or shortness of breath indicate a stable patient. For stable SVT, the initial intervention is typically vagal maneuvers, e.g., Valsalva, carotid sinus massage if physician ordered and no contraindications. These maneuvers increase vagal tone, which can slow the heart rate or convert SVT to sinus rhythm. Synchronized cardioversion is reserved for unstable patients, and antiarrhythmics are typically next if vagal maneuvers fail. Question 14. A patient with acute respiratory distress syndrome, ARDS, on mechanical ventilation has persistent hypoxemia despite high levels of PEEP and FiO2. The nurse notes the patient is in a supine position. The next intervention the nurse should anticipate is A. Administering a neuromuscular blocking agent. B. Initiating prone positioning. C. Increasing the ventilator's tidal volume. D. Decreasing the respiratory rate. Answer, B. Initiating prone positioning. This question addresses advanced management strategies for severe ARDS. The keywords persistent hypoxemia despite high levels of PEEP and FiO2 are key, indicating refractory hypoxemia. In such cases, prone positioning is a well-established and highly effective intervention. Prone positioning helps improve oxygenation by redistributing ventilation and perfusion, recruiting collapsed dorsal lung regions, and improving the matching of ventilation and perfusion. It is a critical strategy to consider before escalating to more aggressive pharmacological interventions or extracorporeal support. Question 15. A nurse is preparing to administer intravenous calcium gluconate to a patient with severe symptomatic hyperkalemia. The nurse understands that the primary purpose of this intervention is to A. Decrease total body potassium stores. B. Shift potassium from the extracellular to intracellular space. C. Stabilize cardiac cell membranes. D. Increase renal excretion of potassium. Answer, C. Stabilize cardiac cell membranes. This question focuses on the specific action of calcium gluconate in the management of hyperkalemia. The key is understanding that while other treatments reduce potassium, calcium gluconate does not directly lower serum potassium levels. Its primary role is to immediately antagonize the cardiac effects of hyperkalemia by stabilizing the myocardial cell membranes, thereby reducing the risk of life-threatening arrhythmias. It is a crucial, rapid-acting intervention to protect the heart while other treatments work to actually lower potassium. Question 16. A patient in hypovolemic shock due to severe hemorrhage has received 3 liters of crystalloid and 2 units of packed red blood cells. Vital signs remain. BP 80/50 mmHg, HR 130 bpm, maps 60 mm of mercury. Urine output is 10 milliliters per hour. The nurse anticipates the next step in management will be A. Administering an additional fluid bolus of crystalloid. B. Initiating a norepinephrine infusion. C. Preparing for placement of a pulmonary artery catheter. D. Administering a diuretic to improve urine output. Answer, B. Initiating a norepinephrine infusion. This question tests the management of hypovolemic shock when initial fluid and blood product resuscitation has been insufficient. The keywords remains BP 80/50 mm of mercury, HR 130 bpm, maps 60 mm of mercury, and urine output is 10 milliliters per hour indicate persistent hypotension and organ hypoperfusion despite what is described as adequate initial fluid and blood resuscitation. At this point, if hypovolemia has been addressed as much as possible, vasopressor support like norepinephrine is needed to increase systemic vascular resistance and improve mean arterial pressure to maintain organ perfusion. Question 17. A critical care nurse is caring for a patient with an intracranial hemorrhage whose ICP has consistently been 20 to 22 millimeters of mercury. Which intervention should the nurse prioritize to manage this elevated ICP? A. Administering a stool softener. B. Maintaining a neutral head position. C. Encouraging deep breathing and coughing exercises. D. Administering a hypotonic intravenous fluid. Answer B. Maintaining a neutral head position. This question addresses non-pharmacological interventions for managing elevated intracranial pressure, ICP. The keywords ICP has consistently been 20 to 22 millimeters of mercury indicate sustained elevated ICP, which requires continuous management. Maintaining a neutral head position and ensuring proper head elevation, typically 30 degrees, is crucial because it facilitates venous drainage from the brain, thereby helping to reduce ICP without requiring medications or invasive procedures. Other options either increase ICP, coughing, are less direct, stool softener, or are contraindicated. Hypotonic fluids would shift fluid into brain cells. Question 18. A patient with acute kidney injury, AKI, requiring continuous renal replacement therapy, CRRT, is prescribed a new antibiotic. The nurse should be most concerned about which aspect of medication administration? A. Administering the medication with food to prevent GI upset. B. The potential for increased drug levels due to altered elimination. C. The need for a slower infusion rate due to fluid restrictions. D. Administering the antibiotic simultaneously with other medications. Answer B. The potential for increased drug levels due to altered elimination. This question highlights a critical consideration for medication administration in patients with AKI and on CRRT. The keywords acute kidney injury and CRRT signal impaired renal function. Many medications, especially antibiotics, are primarily cleared by the kidneys. In AKI, their elimination is reduced, leading to potential accumulation and toxicity if dosages are not adjusted. CRRT also removes some drugs, but the balance of reduced clearance and CRRT removal often necessitates careful dose adjustments to prevent drug toxicity or subtherapeutic levels. Question 19. A critical care nurse is monitoring a patient 48 hours post-ST elevation myocardial infarction, STEMI. The patient suddenly develops new onset crushing chest pain, dyspnea, and a new holosystolic murmur at the apex, radiating to the axilla. The nurse should immediately suspect which complication? A. Pericarditis. B. Ventricular septal rupture. C. Papillary muscle rupture. D. Aortic dissection. Answer C. Papillary muscle rupture. This question describes a specific, life-threatening mechanical complication of myocardial infarction. The keywords 48 hours post-STEMI, new onset crushing chest pain, dyspnea, and crucially, new holosystolic murmur at the apex, radiating to the axilla, are classic signs of papillary muscle rupture. This complication leads to acute mitral regurgitation, which manifests as severe pulmonary edema, dyspnea, and the characteristic murmur indicating blood regurgitation into the left atrium during systole. This distinct presentation differentiates it from other post-MI complications. Question 20. An ABG result shows pH 7.25, PaCO 260 mm of mercury, HCO3 28 milliequivalent/L. The nurse interprets this as which primary acid-base imbalance? A. Compensated metabolic acidosis. B. Uncompensated respiratory acidosis. C. Partially compensated respiratory acidosis. D. Fully compensated metabolic alkalosis. Answer C. Partially compensated respiratory acidosis. This question requires a systematic approach to ABG interpretation. First, the pH, 7.25, is acidic. Next, evaluate the PaCO 2, 60 mmHg, which is elevated, indicating a respiratory acidosis. The HCO3, 28 milliequivalent/L, is also elevated, showing that metabolic compensation is occurring. However, since the pH is still abnormal, acidic, the compensation is only partial. Therefore, the interpretation is partially compensated respiratory acidosis. Question 21. A patient with a terminal illness is experiencing severe intractable pain, despite escalating opioid doses. The patient's family requests palliative sedation to alleviate suffering. The nurse understands that the primary goal of palliative sedation is to A. Hasten death to relieve suffering. B. Induce unconsciousness to control refractory symptoms. C. Preserve consciousness while minimizing pain. D. Prepare the patient for organ donation. Answer: B. Induce unconsciousness to control refractory symptoms. This question addresses a sensitive ethical and clinical practice in end-of-life care. The keyword palliative sedation is crucial. The primary goal of palliative sedation is to intentionally induce a state of reduced or absent awareness to relieve severe and refractory symptoms, like intractable pain, that do not respond to other treatment modalities in a terminally ill patient. It is distinct from euthanasia and is not intended to hasten death, but rather to alleviate suffering during the dying process. Question 22. A critical care nurse is managing a patient with full-thickness burns covering 30% of their total body surface area, TBSA. During the first 24 hours post-burn, the nurse should prioritize monitoring for which critical complication? A. Hypernatremia. B. Hypovolemic shock. C. Hyperkalemia. D. Metabolic alkalosis. Answer: B. Hypovolemic shock. This question focuses on the immediate priorities in the acute phase of severe burn injury. The keywords full-thickness burns covering 30% TBSA and first 24 hours post-burn are vital. During this initial period, massive fluid shifts from the intravascular to the interstitial space occur due to increased capillary permeability, leading to significant plasma loss. This results in severe hypovolemia and a high risk of hypovolemic burn shock, making aggressive fluid resuscitation and vigilant monitoring for shock the highest priority. Question 23. A patient receiving unfractionated heparin for a pulmonary embolism develops a platelet count of 60,000/mm3, down from 250,000/mm3 a few days prior, and a new necrotic lesion on a toe. The nurse should immediately suspect which complication? A. Disseminated intravascular coagulation, DIC. B. Idiopathic thrombocytopenic purpura, IDP. C. Heparin-induced thrombocytopenia, HIT, with thrombosis. D. Vitamin K deficiency. Answer: C. Heparin-induced thrombocytopenia, HIT, with thrombosis. This question describes the classic presentation of heparin-induced thrombocytopenia, HIT, particularly the more severe form with thrombosis. The keywords receiving unfractionated heparin, platelet count of 60,000/mm3, down from 250,000/mm3, and new necrotic lesion on a toe are highly indicative of HIT with thrombosis. HIT is an immune-mediated adverse drug reaction where antibodies to heparin platelet factor IV complexes cause platelet activation, leading to thrombocytopenia and a paradoxical prothrombotic state. Recognizing this immediately is critical as heparin must be stopped and alternative anticoagulation initiated. Question 24. A patient with known adrenal insufficiency presents with severe hypotension, intractable vomiting, and hyponatremia. The nurse anticipates the immediate administration of which medication? A. Intravenous insulin and dextrose. B. High-dose intravenous corticosteroids. C. Oral fludrocortisone. D. Intravenous potassium chloride. Answer B. High-dose intravenous corticosteroids. This question describes a patient in acute adrenal crisis, a life-threatening endocrine emergency. The keywords known adrenal insufficiency, severe hypotension, intractable vomiting, and hyponatremia are classic signs of this condition, resulting from an acute deficiency of cortisol and often aldosterone. The immediate, life-saving intervention is high-dose intravenous corticosteroids, for example, hydrocortisone or dexamethasone, to replace the deficient hormones. Volume resuscitation with normal saline is also critical to address the hypotension. Question 25. A patient with chronic heart failure is admitted with acute decompensated heart failure, exhibiting severe dyspnea, orthopnea, and crackles bilaterally. The nurse notes a blood pressure of 88/50 millimeter of mercury and a heart rate of 110 bpm. The immediate priority intervention is to A. Administer a beta blocker to reduce heart rate. B. Administer an intravenous loop diuretic. C. Initiate a positive inotropic agent. D. Administer a peripheral vasodilator like nitroglycerin. Answer C. Initiate a positive inotropic agent. This question presents a complex scenario of acute decompensated heart failure with signs of cardiogenic shock. The keywords severe dyspnea, orthopnea, and crackles bilaterally indicate significant fluid overload, while blood pressure of 88/50 millimeter of mercury and heart rate of 110 bpm point to severe hypoperfusion and compensatory tachycardia. In this cold and wet presentation, congested but hypoperfused, the priority is to improve cardiac output and perfusion, which is best achieved with a positive inotropic agent, e.g., dobutamine, to enhance myocardial contractility. Diuretics and vasodilators are usually prioritized in patients with adequate blood pressure, and beta blockers are contraindicated in acute decompensated heart failure with hypotension.